Assalamu alaikum, ladies and gentlemen. Good afternoon and welcome from Gets Pharma Webit Learning Cell. This is Samidur Rahman representing Gets Pharma. As you know, amid COVID-19 scenario in Pakistan, unfortunately, chronic diseases and the need of various surgeries have not ceased to affect our patients. जिसकी वजह से पेशेंट्स और डॉक्टर्स दोनों में ये गैप है और उसको गैप को फिल करने के लिए हमारी एक काविश है. For the same reason, we bring to you top of the line experts of their field to bridge that gap and to show us the way forward. Today's our topic of discussion is urological surgery amid COVID-19 era. For this keynote speech, we have a keynote speaker, Professor Dr. Ahmed Fawad साहब. वैसे तो ये किसी तारुफ के मोहताज नहीं है, but एक फॉर्मेलिटी है कि हमने इनके इंट्रोडक्शन करवाना है. Professor Dr. Ahmed Fawad साहब is professor and head of urology, Dr. Ziauddin Hospital, Karachi. He is a leading urologist. He is also the ex-president of Pakistan Association of Urological Surgeons. With him, he brings more than 35 years of experience of clinical experience and teaching. So without any further ado, I would like to request Professor Ahmed Fawad Saab to share his thoughts on the topic. Sir, over to you.
Assalamu alaikum. Now, we are talking about urological surgery in the COVID-19 era. Now, if anybody claims that he's an expert in this, then I'm sure it's not true. Because what's happening is a surprise for the whole world, and all of us are learning in this process. I am learning, you are learning, and so are so many people who are learning. But the most important thing is that we should share our experiences so that with those shared experiences, we are able to make decisions, because the situation is changing day by day. We are actually standing on quicksand and we don't know what tomorrow is going to be like. Today, we may be passing through a phase where we have low incidence of the disease, but looking at other countries, tomorrow we may be having a very high incidence of disease. So we must be prepared for today and we must be prepared for tomorrow. Now, COVID-19 pandemic, and what's a pandemic? Pandemic is a global epidemic. And there are no standard guidelines in what to do and how to do and so on, but they are evolving with the situation, which has to be dealt with the available knowledge and the common sense collective decision making. The nature of the threat defines what you are looking at, and the threat here is the coronavirus, which is similar to the SARS virus and the MERS virus in the past, and is said to originate from the bats, which are one of the animals or mammals that have been harboring it. The issue is the speed of transmission and highly infectious nature of this virus, which is the biggest challenge. And that's the reason that we all are worried about, and the whole world is in a panic. I'm sure you've seen a lot of pictures of this, why this is called coronavirus. The black and white picture shows the actual electron microscopic view of this virus, which is very much like the diagram that is being depicted. Why are we worried? In the next few slides, I'll be sharing a comparison with MERS and SARS-1 incidences. The other thing is that as it seems at the moment, with no treatment, for those who become seriously ill with a respiratory issue, the only hope is a ventilator. But the question is ventilator the panacea? The patient and the caregiver both are at a risk of transmission, and so it's not just a matter of saving one or the other, it's a matter of saving the patient and also protecting the caregiver. Now, if you look at this chart, this is from the study of the first 41 cases from Wuhan. Now, the COVID-19 is December 29, but probably there were some symptomatic patients even back in November. The MERS originated in Jeddah, Saudi Arabia in 2012, while the SARS-1 originated in Guangdong in China. Now, the things I'd like to highlight is the mortality rate for MERS was 37%. For SARS, initial one was 10%. And from these figures from Wuhan, it is depicted as 2.9%. But as we are seeing in real life, the mortality and the incidence is varying from region to region. The worst hit as far as mortality is concerned are Italy and Spain. And America, as far as total number is concerned, is leading. But again, relative mortality, and again, the word is relative mortality, is probably better than Spain and Italy. And the other interesting figure that you would see from here is the healthcare worker involvement, which was up to 23% in SARS-1, and it has been quoted from Wuhan, and about 16% of the caregivers were involved with this. So it is definitely a threat both for the patient and the caregivers. And mind you, even young caregivers have been affected and even died. So it is a genuine threat. Now, as I was saying earlier, what about ventilators, which at the moment with no treatment, no vaccine available, seems to be the only panacea? Now, the paper from China with 710 cases showed that 52 were admitted in ICU. And out of those who got ventilated, 86% died. Another study reported 97% death rate. Then a question on Twitter floated by the author to various people who were in touch with patients or with the healthcare systems which are looking after. They gave a mortality rate variable between 25 to 70% of those who went on the ventilators. Probably the most authentic is the Intensive Care National Audit and Research Center from the UK, which shows that amongst those who go onto a ventilator, 66% died, as against a 36% mortality of normally in an ICU setting on those patients who are on ventilator. So there's almost a doubling of that 2/3 who have gone on the ventilator have died. So there is a serious issue. So much so that this is a news item as well. And at the moment you're collecting information not only from journals, but also from news item, because the news media is very much informed and up to date on the medical developments as well. And some critically ill patients chose just to stay at home rather than going into a hospital and onto a ventilator and have the pain and passing through all those stages. So we are between the devil and the deep sea. Very difficult choices, but we have to make them. The choices are when there is no cure like a medicine, or when there's no vaccine, so how do you prevent? And the only thing that's emerged is social distancing, so much so that today social distancing has been accepted by Oxford Dictionary as a noun. And this is a recently created. Social distancing is, if it is very effective, then it has a physical and economic lockdown. And we all are seeing that across all spheres, worst in some areas than others, but we are seeing that. In a hospital setting like elsewhere, the options are between suspending all the facilities, the routine activities to prepare for a load of COVID-19 patients to be coming in and to be preventing cross infections. But at the same time, we are looking at a financial shutdown, not only of the economy, but also of the hospital, which would mean that many staff would be going on to reduced salaries, or many may be laid off. Now, this is a real issue. Talking of the government, the whole economic wheel is in a jam. So with no revenues coming from the taxations that the government's source of income is, again, government is in a difficult position to help. Talking of elective patients, now what is happening is elective patients are going in the background, but at the moment as we stand, and with the days, the number of days increasing from 2 weeks to 3 weeks, and maybe 4 weeks, maybe 6 weeks, 7 weeks, because Wuhan was closed for 72 weeks, we are looking at routine surgery being indefinitely delayed unless and until we develop some form of triage. And I think some of our discussion is going to be focusing on prevention of infections, and at the same time, how to develop a triage system, taking from whatever evidence is available in literature at the moment. COVID-19 and kidney disease, there's a definite association, and in hospital death. And this is a study of 701 patients with an average age of 63 years, with the severe illness in 42 and comorbidities another 42%. And they had a 16% death rate of in-hospital patients. Now, this is another very interesting slide. Unfortunately, the corner is a little hiding behind the picture, but I'll just mention the figure. What is being showed here is that what specimen types the SARS-CoV-2 virus has been picked up from. 93% from bronchoalveolar lavage, 46% from brush biopsy from fibrobronchoscopes, from the sputum 72%, from nasal swabs 63%, pharyngeal swabs 32%, feces 29%, but from a surgical perspective, from blood only 1%. And the figure, which is may not be visible because it's on the corner of the screen, and that is urine, no specimen was picked up. This study was published in JAMA, and it comes out from 3 hospitals in China linked to a university from where these statistics were published. Now, this shows us that who's at risk? The anesthetist and anybody of the support staff or anyone who comes in the range of at the time of intubation or at the time of anesthesia or at the time of at the recovery, when the patient starts to cough. Now that is the time that a person becomes highly susceptible to getting infections, and that is the area one has to really look for if you are operating on patients who are COVID positive. Now here is a study which is, again, this is a little doubtful study. It's not been yet published, but this was a news item of a telephonic call that one of the other institutes from China said that they were able to pick up the virus in every urine sample, but this is yet to go through peer review, and this was just a telephonic conversation, so the reliability is still questionable. Viral shedding is another issue because that determines that how many days you are potentially going to be infected, or you can have an infection. But mind you, not always does RNA shedding does not always cause infection. So that is something which will have to be taken into perspective. You may have viruses identified 1 to 2 days prior to onset of symptoms, and it can persist about up to 12 days in moderate cases and 2 weeks in severe cases. In feces, viral RNA has been detected from day 5 and up to 5 weeks. Also been detected from whole blood, serum, saline, and urine, and I've mentioned the figures above. Prolonged viral RNA shedding has been reported for nasopharyngeal swabs up to 37 days. But mind you that viral RNA alone does not mean transference of infection, and this is something we need to note. Talking of guidelines. Now, you talk of guidelines, you make guidelines standing on shifting sands, and within a week your guidelines are dated, and you have to review them. Maybe not the whole, but some of them. But still, we have to have a starting point somewhere. Now, these are guidelines for personal protective equipment, which I've taken from an article published online from Wuhan University, and a rapid advice guideline for diagnosis and treatment of novel coronavirus. Now, if you look here, the items, the personal protective equipment that is mentioned on the top, you have the exposure intensity, and then you have the hat, the N95 mask, coverall, eye protector, latex gloves, barrier gown, protective clothing, shoe covers, and comprehensive respiratory protection. And on the vertical side, you can see the areas as per area: the pre-examination, triage area, the general outpatient, general ward, fever clinic, isolation room, and department of infectious diseases, and varying degrees of what has been practiced in that particular hospital over this period of time. They develop those guidelines. These are the guidelines with the same parameters on the top, but on the left hand vertical column, You have the, according to the personnel, depending on the medical staff in the isolation area, in the pre-examination area, in the outpatients, in the wards, assisting staffs, and administrative staff. So all that has been mentioned on that. Now, here is something that's coming out of University of Kansas Health System, where if you may actually see, there may be some differences with the guidelines that you have seen earlier. But here they have classified the patient into of those not suspected of COVID, those who are suspected or positive of COVID, and those who are undergoing aerosol generating procedures. And we've already mentioned those, which are like anesthesia, intubation, bronchoscopies, suctions, nasotracheal suctions, and so on and so forth. So these are the guidelines as far as that is concerned. What is the Karachi scene? This I have taken from a personal communication with colleagues and peers in different hospitals in Karachi. And what is happening here is that most major hospitals have either made a separate triage or have designated a specific isolated area for the same purpose. Hospitals with policy to admit and manage COVID-19 patients have also isolation wards, and then there's a step up to ICU. While other patients who do not have these facilities or who are not designated as COVID treatment centers, they refer these patients elsewhere. Then the use of personal protective equipment varies from institution to institution, and in the same institution also varies from area to area, where the likelihood of the transmission is considered to be higher. There is more intensive PPEs. All elective surgeries in all the hospitals that I talked to had been for the moment postponed. Emergencies were still being dealt with, and many elective surgeries become emergencies in certain situations. And the routines could vary from hospital to hospital. And some hospitals were testing for COVID-19 those who had the facility before undertaking any surgical procedure. Now, these are, if you go onto the European Urology site, there is a corner called Resources for COVID. Out there, they've got the European Urology recommendations for this, and this is published on the 15th of March. And this is coming out from hospitals in the USA, in Italy, and the UK. So they have combined, they put their thoughts onto it and developed a certain triage. This triage not necessarily will be the same for everyone, but these are guidelines and everybody has to look into their own perspective. But the question is that why are we doing a triage, or why are we prioritizing patients? And the first thing is that we need intensive care facilities available for seriously ill, and to prevent patient to patient and patient to provider transfer of the infections, for which elective surgeries could be postponed, but emergencies will continue. But here again, the word elective is open to interpretation because that depends from the individual facilities, availability of facility, and the degree of severeness of the patient. Prioritizing means just you have to categorize them. The more urgent gets the priority, and do it according to your, but here are the broad guidelines which this European Urology paper is giving us. Now, what I've done is, for the ease of everyone, and these will be important for anybody who wants to use them as further reference, is I've summarized the recommendations. Those are big charts and that you have to go into a lot of details, but here I've summarized what's the bottom line. For bladder tumor, what has been suggested is that any tumors more than T1, or they are profusely bleeding tumors, TU or BT, because some of these, or quite a few of the T1 plus tumors may be understage and may be muscle invasive. The other thing is that delaying cystectomy for more than 90 days increases the risk of nodal involvement. In testicular cancer, oophorectomy can be done as an outpatient procedure, so minimal exposure and all precautions can be taken. Prostate cancer, most radical prostatectomies can be delayed. ADT and radiation can continue, and in ADT also best to have the long-term formulations like 3 to 6 months formulations rather than having the monthly formulations. Trust biopsy is to be decided on the degree of suspicion and on individual basis to basis, and these are guidelines from the NCCN, not from this particular paper. Renal cancer, nephrectomy is 3 plus, and anything involving renal vein or IVC should be undertaken. T1 masses treatment can be either delayed or ablative therapy can be considered as an alternate. T2 masses can be delayed but needs to be individualized from case to case. Now talking of upper tract urothelial carcinomas, and here more than 3 months of delay can increase the progression. So decisions have to be taken accordingly. Adrenal tumors, more than 6 centimeter tumors are likely to harbor malignancy and need to go have a relative urgency of doing, while less than 6 and with favorable radiological appearance, one can wait on them. Penile urethral cancer is very infrequent, so the data on that is very limited. So again, individually one has to decide. Now coming on to benign conditions. Amongst that, when there's stones and there's obstruction, stents and PCN is the work, and even consider bedside awake stenting by just giving IV sedation. Indwelling stents which have been there, I'm sure if they can be delayed a few more weeks before taking them out. And BPH, all procedures can be delayed, and those who are severe symptomatic or those who are in retention need to be catheterized. Stress urinary incontinence can be delayed. Nerve stimulators, new placements should be delayed, but those who have placements being done and the external leads are present have a higher risk of infection, so either remove them or plan for the second stage. VVF and RVF broadly can be delayed unless until there is sepsis, and so drainage procedures like catheters or colostomies can be done. Artificial sphincters, penile implants, mesh, removal only if they are infected. Urethral obstruction, all procedures can be delayed. In worst case scenarios, suprapubic catheters can be used. Erectile dysfunction, infertility can be delayed. In transplant, now in transplant, most transplant surgeries are being delayed, but deceased donor transplant, because that organ will not be available again, are still being considered, but live donor transplants are being postponed. And this is, I'm talking internationally, so I'm sure there'll be local guidelines on the centers that they are doing these procedures. In general urology, drainage and debridement of soft tissue infections and abscesses. In ischemia, shunting for priapism, detortion, and orchidopexy. If there's hemorrhage, consider accordingly. Trauma, consider accordingly. Pediatric urology, torsion is an emergency. GU obstruction, again, Foley, suprapubic, and PCM. Now, these are the general guidelines which are coming out of these 3 centers. But again, as I said, that we have to individualize to our circumstances, and as the time goes on, because of the same period, for the moment we are hoping that it's over within a matter of 2 weeks. But if you're looking at it's not over within a matter of 2 months, then we'll also have to consider how do we start doing elective surgeries in a more safer environment. So all these things will develop as we go along and as the situation changes. Now here I come to another topic, and that is for the individual practice or even for the hospitals. And that is that how do you reduce your outpatient load and still have access to the patients, and at the same time you can continue this thing into the normal days as well. And that's the option of telemedicine. Now telemedicine, one way that has been practiced is that you have a center in a major medical institution, and then you've got satellites in the remote areas, and there are some medical personnel in the satellites who see the patients, who give you the overall, they connect with you on live video, and they take the advice, and the patient is advised accordingly. But in this time and all, I think we have to evolve a system where we should be able to have direct patient to doctor contact, but at the same time maintaining the time privacy of the doctor, but at this, and also access to the patient. So both things have to be considered. Some people that I know, what they are doing is that either they have a separate phone for this, or their assistants are getting on a set performer history from the patient and the investigation that passed on to the doctor. The doctor gives them the advice on WhatsApp, which is passed on to the patient, and the patient then takes the medicines or gets investigations done and again contacts the doctor. Now, this all is fine at the moment in the era where there's a lot of desperation and the patients are in a difficult situation to continue doing that. And we should all be probably doing this thing in a complementary manner. But for the long term, one will have to be looking at definitive financial arrangements, because if this has to be made a long-term practice, then financial arrangements should be made for the benefit of everyone. In this, I'm sharing a link which you can later on click upon and then check this out. This is from the American College of Physicians, mainly made for the US-based practices, but I'm sure there's a lot to learn. This is like a workshop setting where you learn, and then there's question answers where you answer to see how much you've understood what this is. And this is telemedicine, a practical guide for incorporating in your practice. Concluding, an ever-changing situation requires an open mind and collective decision-making depending on the resources of the healthcare facilities available. We have to think out of the box. There may not be one right for all decision, and they have to be individualized accordingly. So stay safe, but can't stay at home unless comorbidities may make it more prudent to do so.
Thank you very much, Dr. Saab, for this such an informative session. और आपका जो एक्सपीरियंस था अबाउट सर्जरी, यूरोलॉजी और खासतौर पर टेलीमेडिसिन का, तो उसने हमारे लिए सोचने के लिए एक और वेन्यू खोल दिया दिमाग में. आई हैव नंबर ऑफ क्वेश्चंस टू डिस्कस विद यू, जो कि हमारे साथ हमारी ऑडियंस ने पूछे हैं. मैं वन बाय वन आपसे पूछता हूँ सो दैट यू कैन आंसर देम इंडिविजुअली. पहला क्वेश्चन जो है वो टेलीमेडिसिन से लिंक करता है. अकॉर्डिंग टू यू और योर एक्सपीरियंस, how evolved is our telemedicine system if compared to the western world? पाकिस्तान में जो टेलीमेडिसिन का सिस्टम है, पेशेंट्स की अंडरस्टैंडिंग है और जो डॉक्टर्स का उसका यूजेज है, वो कितना इवॉल्व है या कितना अभी एवोल्यूशन फेज पे है एज कंपेयर टू एनी अदर कंट्री ऑफ द वर्ल्ड? सर,
इसके रेफरेंस में I'll give you in the Musharraf era, telemedicine task force was made. I was part of that task force. उसके बाद some of the centers that picked up telemedicine development, one was Rawalpindi General Hospital and the other one was Khan. I'm sure there must be other centers as well, which I'm not quite aware of, but these are the centers which were practicing with the video conferencing. But prior to that, they had satellite units where their junior doctors would see the patients, make a summary, send the patient summary by email. So before the patient came on for a consultation, the doctor already had a summary before him and they would do a consultation. So on those patients who did not need to be referred to the main hospital, they were dealt with there and then. But those who needed to be referred to the main hospital, they were referred from here. The other example that I just gave earlier was trying to develop this either through telemedicine sites, which I'm sure you all are facilitating, and I'm sure this is going to come to be a very nice software. And I also gave you the example of how it is being practiced on WhatsApp. So those are the things that one can consider as far as telemedicine is concerned. But as I said earlier, anything to be lasting for a long time and to become as part of the system must have some sort of a financial arrangement, unless and until it is either paid for by the government, but then somebody pays somewhere.
Thank you very much, sir. I have another question with you. Is the post-surgery care for a patient suffering from COVID-19 any different from a routine post-op care, regardless of whatever happened first, either COVID-19 or the surgery? Because might be possible कि कोई patient जो है वो surgery के बाद COVID-19 से infected हो गया. So the post-op care is any different with any routine patient or not?
देखिए, इसमें वो जो मुझे समझ में आता है, actually again I can't be talking from my experience, as I stated at the start. I'm talking from collective wisdom which is coming through from the various centers and the countries where this problem is much more. as far as patient care is concerned, once he's in a hospital setting, then the patient care is no different from what it is for a normal ward. The only difference is your protective care has to become much more. You have to be protected, everybody dealing with the patient has to be protected, and the patient next door or the patient, other patients in the hospitals have to be protected. So those protections have to be taken. As far as the condition is concerned, that is, the treatment of that will still remain the same for everyone.
ओके, परफेक्ट सर। और इसमें पोस्ट ऑप केयर में किस तरह का पेशेंट और डॉक्टर्स को भी अपनी जो पर्सनल प्रोटेक्शन है वो भी इंश्योर करनी है, क्योंकि डॉक्टर्स जो फ्रंट लाइन वॉरियर्स हैं हमारे, और उनकी सेफ्टी भी हमारे लिए बहुत बड़ा कंसर्न है।
Very true, because any the interesting thing is कि जो इसमें जो चीज सामने आ रही है कि amongst the healthcare providers, the younger ones are getting infected and they are dying. यानी अभी उस दिन हेडलाइन में थी a Pakistani nurse working in the UK, 36 years of age, and she died of COVID-19 and she had no comorbids. So probably we are looking at high viral loads, which is probably one of the considerations when you are in a direct contact. So those considerations have to be taken. So this is a definite consideration and issue.
Thank you very much, sir. Sir, one more question that I have. Although अभी इसका शायद data बहुत ज़्यादा ना हो, but I still am going to ask you, what's the recovery rate according to the literature? What's the recovery rate of COVID-19 patients having renal diseases? I know कि इसका बहुत ज़्यादा data भी publish नहीं हुआ होगा, but what's your take on it?
मैंने एक स्लाइड शेयर की थी आपसे रीनल डिजीज के साथ. इन हॉस्पिटल मोर्टेलिटी इज 16%.
16.
ठीक है. So all the rest one would consider to have recovered or have gone back to a certain baseline, maybe not gone to normal, but have gone back to a certain baseline. So that's the best that I can say. And this figure comes from the journal Kidney, published by the International Society of Nephrology.
Thank you very much, sir. Sir, one more question. Basically, for those patients जिनको डॉक्टर्स ने टाइम दिया हुआ था फॉर द इलेक्टिव सर्जरीज, एंड एज यू टोल्ड के हुआ तो वो डिले हो गई हैं या पोस्टपोन हो गई हैं अंटिल एन इमरजेंसी कंडीशन इज अराइज, तो उन पेशेंट्स के लिए क्या काउंसलिंग पॉइंट है? क्योंकि वो तो परेशान होंगे कि यार हमारी सर्जरी थी और हमें टाइम मिला हुआ था, बट वी कैन नॉट गो आउट, वी कैन नॉट विजिट द हॉस्पिटल्स और डॉक्टर्स या हॉस्पिटल्स भी हमें उस तरह से एंटरटेन नहीं करे, तो उनके लिए क्या काउंसलिंग पॉइंट है?
देखिए, उनके लिए जो जवाब है वो ये है कि उनको समझने की ये जरूरत है कि ये क्यों किया जा रहा है. यानी हम उनको बुला के हॉस्पिटल में ऑपरेट कर देते हैं, लेकिन अगर हॉस्पिटल्स उनको क्रॉस ट्रांसमिशन ऑफ हो जाता है, चाहे ओपीडी में बैठे हुए, चाहे वार्ड में दाखिल होने के बाद उनको क्रॉस ट्रांसमिशन ऑफ इन्फेक्शन हो जाता है, वो बाद में उससे सीरियस हो जाते हैं, तो क्या किया जाए? और इस वक्त जब इस मर्ज का इलाज मौजूद नहीं है और कोई वैक्सीन नहीं है और ना हर्ड इम्यूनिटी डेवलप हुई है इन द कम्युनिटी, तो द ओनली वे टू प्रोटेक्ट इज डिस्टेंसिंग. देखिए, आप अगर किसी भी हेल्थ केयर सिस्टम में जाइए, वहां पे नॉर्मली इलेक्टिव केसेस को 6-6 महीने, साल बाद का टाइम दिया जा रहा होता है. तो हमारे यहाँ तो कुछ जगहों पे वो भी सही है कि लंबे टाइमिंग्स हैं, लेकिन कुछ जगहों जैसे प्राइवेट सेक्टर के अंदर मरीज जाते हैं एंड विद इन द नेक्स्ट वीक और फ्यू वीक्स they are able to have surgery done. So the important thing is for the patient to understand that this is being done for their benefit, and to take out time and to take out the equipment for the benefit of those serious patients who are in hospital without COVID, and those serious patients will come into hospital with COVID.
Sir, thank you very much. I guess that's all for now. Sir, आपका बस अगर कोई मैसेज है फॉर डॉक्टर्स एंड फॉर पेशेंट्स और फॉर पाकिस्तानी पीपल, तो प्लीज अपने मैसेज पे डिस्कशन को कंक्लूड कीजिएगा.
जी, certainly I do have a message, and that message is that which I said in my opening of the talk, that we are standing on quicksand और आपके नीचे की जमीन रोज बदल रही है. ठीक है, एक मुल्क के हालात कुछ हैं, दूसरे मुल्क के हालात कुछ हैं. एक ही खित्ते में एक तरफ के हालात कुछ हैं और एक तरफ के हालात कुछ हैं. So the only way that we have to go forward is by collective decision making. No one decision is going to be ideal. तो इसलिए जो हमारा अनफॉर्चुनेटली मीडिया कर रहा है और कुछ पॉलिटिक्स भी खेली जा रही है कि उंगलियां उठाई जाती हैं कि ये गलत किया, ये गलत किया. जवाब किसी के पास भी नहीं है कि असल सही जवाब क्या है. जवाब डे टू डे वेरी कर रहा है, और आई थिंक इसके अंदर ताउन एक दूसरे के साथ और समझ की जरूरत है, ताकि एक दुश्मन जो नजर नहीं आ रहा, जो मूजी है, उसके खिलाफ कैसे फैसले किए जाए।
Sir, with this very important message कि uncertain times हैं, so there is no right question. The question might be, answer might be right for that one instant. So, sir, with this concluding remark, thank you very much, sir, for your time, for your expertise. और जो अगर कोई क्वेश्चंस होंगे तो फिर हमसे दोबारा आपसे पूछ
मुझे
के
व्हाट्सएप पे फॉरवर्ड कर दीजिएगा, आई रिप्लाई। ठीक है,
ओके, थैंक यू वेरी मच,
थैंक यू वेरी मच, थैंक यू।